Hello, and thank you for joining this Onc Live TV Peer Exchange. This program will feature expert panel discussions on key topics related to advanced colorectal cancer. I'm John Marshall, and I'm Chief of the Division of Hematology Oncology at Georgetown University, and I'm also the Director of the Rush Center for the Cure of GI Cancers. Joining me today are some of my best friends and the smartest people on the planet around colorectal cancer. Dr. Axel Grothe, a professor of oncology and consultant in the Division of Medical Oncology in the Department of Oncology at Mayo Clinic in the coldest place in the United States, Rochester, Minnesota. Axel, welcome. Next to me, Dr. Dan Haller, Professor Emeritus and former Georgetown person at the Abramson Cancer Center at the Perelman School of Medicine. Herb Hurwitz, Professor for the Division of Medical Oncology at Duke University Medical Center, and Dr. Alan Vanook, here from San Francisco, where we're coming to you live, Madden Family Distinguished Professor of Medical Oncology and Translational Research, and the Professor of Clinical Medicine for the Division of Medical Oncology at the University of California, San Francisco. Thanks to each of you for taking some time out of the meeting this morning to kind of get together and give all these folks out there really a pretty crisp update of what's going on in colorectal cancer. Thanks, guys. All right, so we're going to start actually, I know we're talking metastatic, but how do we keep people out of our office in the first place? I really want to talk about screening. What is the proper screening for colon cancer? Dan, let me pick on you first. You know, who out there in the general public should be getting colonoscopies, and are we doing it right?
The answer is I think we're doing it better. I think the most exciting data is coming out of the ACS annual statistics for oncology was the reduced incidence and mortality of colon cancer in the United States. It's, if I remember correctly, roughly a 20% drop over the last decade. That's pretty exciting considering the fact that we're an aging population. You'd expect it to continue to rise. What does it do to? I think it's a combination of more than half of people getting colonoscopies, so getting their polyps removed and getting early detection, and maybe some lifestyle changes that we'll be talking about, including more exercise, perhaps more vitamin D and other things. So I think it's an aspirin. I think it's a combination of, as usual, of multiple factors, known and unknown.
Yeah, around the world, here, let me pick on you. So colonoscopy is our sort of gold standard in the United States, but rest of the world, no. It's fecal occult blood, it's sigmoidoscopies. What do you think is the right screening test? Are there any news out there for new screening tests?
Yeah. So the best test by far is going to be colonoscopy. And I think extra effort should be made to try to make that available to everybody. There's a new test that looks at a molecular profile in the stool. It came out of Axel's Mayo Clinic and is available. This is one of several sort of companion tests which I think will help with screening, but the gold standard really remains colonoscopy, and I think these tests are useful. Annual evaluation by physician, your annual exam is debatable, but probably useful. But the biggest thing by far, colonoscopy, and lifestyle, diet and exercise, and you don't want to be looking like us, so sort of a little out of shape, and as we sort of hit late middle age.
Yeah, and so that brings up the point: is 50 the right age? I mean, if your clinic is like mine, half of it's under 50 nowadays, and so these are a bunch of 30-year-olds and 40-year-olds who have colon cancer and never be screened. Is it time to really rethink, Alan, the guidelines and who and when we screen people?
Well, I think I'd rather first succeed in screening the people who are at greatest risk. Colon cancer and rectal cancer are diseases of the aging, and so the median age of patients diagnosed is in the late 60s. I don't think it would be efficient for us to look at 40-year-olds yet, but what clearly we need to do is identify the at-risk population. The at-risk population, people with a familial history, for example, that's one of the weakest aspects of our analysis of a lot of patients. What's the family risk? I think if we work better at that, and we're doing better, we could identify patients who should be screened at a younger age, but generically I would still stick with 50. I think there was a great paper in the Journal of Clinical Oncology about a year ago now in Delaware, the state of Delaware, where they made a concerted effort to screen people. It started out looking to get rid of disparities between African Americans and others in outcomes from colorectal cancer by getting everybody on the same page, the insurers, the health plans, the employers, the government, they were able to almost eliminate colorectal cancer in Delaware in a 5-year period. Now, this is only a 900,000 person state, so it's not clear that you can do it broadly. But the point is, if you really put your efforts into it, you can really you can make a big dent on the disease.
Axel, I'm going to throw you a curveball. So should I send my blood to 23andMe and find out if I'm going to have, now we've got partnerships and all around genetic profiling. Do you think there's going to be something to that where I'm going to find some at-risk genes where I know I need to be screened sooner?
You might find at-risk genes, but I don't think this is something I would recommend for a whole population, because interpretation of these data is very difficult and actually requires really supervision. And sometimes we don't even know as experts what to do with these data. I think we should, as Alan said, put emphasis on something that we know works, which are established screening tools, And coming back to the age group, we see the group of patients that increases most right now in terms of age group with the incidence of colorectal cancer is actually the under 50. Right. More and more data, so there are actually some efforts to move the onset of the population screening down to, let's say, 40. And we already do this, for instance, for first-degree relatives, kind of sentinel age of the person with colon cancer minus 10 years. So I think there are efforts to kind of get away from this fixed 50-year threshold for screening.
Do you think that's change in biology or recognition? We're just picking up more earlier stage, or there's something, it's in the coffee or something?
A good point, because you can see that those patients who are under 50 don't get screened routinely. Yeah. But I actually also believe that there might be more evidence that there's a change in biology. Something is going on, and it probably has to do with obesity, alcohol consumption. It's lifestyle changes, which we'll hopefully talk about.
Okay. And John, I think one of the most important thing is one of our issues is familial syndromes. And of course, we all know about Lynch syndrome and FAP, and those are the most obvious. But the cheapest screening tool is talking to the patient and taking a family history. And even Henry Lynch will say there are certainly people with family histories and family syndromes that don't have a name yet. But we know they exist, like pornography. You can't define it always, but you know it when you see it. So talking to the patient, getting a good family history, and looking at lifestyle issues may be the best tool.
I couldn't, in this